Hello, and welcome to the Alabama Public Health Training Network. I'm Brandon Vaughn with the Alabama Department of Public Health. Thank you for joining us today for our program, Unexplained Pediatric Deaths, Investigation, Certification, and Family Needs, Procedural Guidance, and Key Considerations. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on the screen now and will appear again later in the program. Also, the handouts and evaluation are available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses, social workers, attorneys, EMS, and law enforcement for this program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 2 years for nurses and social workers, expiring September 30th, 2022. If you are watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in, along with your sign-in sheet and evaluation. If you're watching this program live, there is no social work test required. For social workers, if you're watching this program live, it qualifies for classroom hours. If you're watching on demand, it is considered non-classroom hours. Before we get started, I'd like to introduce our presenter today, Dr. Brandy McCleskey, forensic pathologist with the Jefferson County Coroner's Medical Examiner's Office and assistant professor in the University of Alabama at Birmingham Department of Pathology. Welcome, Dr. McCleskey. I know you have a lot of important information to cover today, so let's go ahead and get started with your presentation.
Thank you, Brandon. I'm excited to be here today to talk to you about a project that I was a part of as a member of the National Association for Medical Examiners panel on sudden unexpected death in pediatrics. It's a group of which I'm very passionate about, as are the other individuals who are on the panel. I just want to mention I have no disclosures that are relevant. The motivation for the panel in general was to look at the individuals that lose their life unexpectedly in the pediatric age group. These are a few pictured here who are members of the Sudden Unexplained Death in Childhood Foundation who sponsored the work. It was a collaboration between the National Association of Medical Examiners, the American Academy of Pediatrics, and then the book which was published by the academic forensic pathologist. This is just a list of the panel members who were responsible for the publication. These individuals range from experts in pediatrics and forensic medicine, in death investigation, as well as members from the NIH and the CDC. The result, as I mentioned, was this publication of a reference textbook on unexplained pediatric deaths, which was the culmination of a massive amount of work over 3 years, fully supported by the SUDC Foundation and published by AFP. It has been made available for a number of named members and state coroners here in Alabama, but is publicly available on Amazon. The objectives of this presentation would be to allow you as the participant to understand what constitutes an unexplained pediatric death, hopefully to apply the principles and guidelines to your investigative and certification methods, as well as just overall medical legal death investigation practice. And hopefully by the end of this presentation, you will recognize the value in a standardized certification practice, as well as that impact that it will have on vital statistics and an overall role in public health. These are the sections that I'm going to cover throughout this talk. These are also sections within the textbook, so if you would like more information, you can find that within the reference text. Before we get to the end, I think it's important to understand how we began. And so the concept of infant and child mortality has been discussed and around, of course, since the beginning of time. It wasn't until the 19th century that children actually began being autopsied, and so we were able to get valuable data from those autopsies. In 1830, Dr. J.H. Kopp actually described a concept called thymic asthma as being the cause of death in this population. That was debunked nearly 30 years later when we realized that the thymus is actually large normally in the pediatric population before it shrinks and undergoes this concept of thymic involution, which is normal. Despite it being debunked, it was still used to, in a court case, when a girl was serving time for a child death in her custody some 50 years later. This really was the beginning of a continued battle that is still to this day around and still applies between natural and unnatural means. There's really a great divide between experts was for over 14 decades with this concept of overlay being where an individual lays on top of an infant, and then later just using the word child abuse. It took a long time for that to become a concept, and that was the reason for these children dying. So in 1982, right at the end of the 19th century, Dr. Templeman actually published 258 cases of infant death that were due to accidental overlay. And now we look back and see that this was probably the earliest description of associated risk factors with sudden unexplained death in infancy. Once the 20th century began, Dr. Bruce Beckwith, who has a number of notorieties, he's a pediatrician, really was adamantly opposed to blaming the parents. In the early 20th century, it was unheard of, or at least not well publicized, that caregivers or parents would harm their children. So they were really focused on that this is just a syndrome, a sudden infant death syndrome, which he and Maria Valdez de Pena would go on in the next few years and name, actually. In this time, another physician published on a risk factor of prone sleeping position. This was in 1944, but I'm sure you guys remember that it wasn't until the 90s that the pediatric groups, Association of Pediatrics and other health professionals, finally started the public health initiative for Back to Sleep campaign. I'm going to talk about that a little more in the next few slides. At this point in the mid-20th century, natural means were becoming more frequent as the causes of death. Those were really respiratory illnesses or bacterial infections. Up to this point, many thought that we could actually diagnose suffocation with an autopsy. And so in 1956 and the few years following that, they finally disproved the concept that there were diagnostic findings of suffocation. There were just associated findings in the same way that there are associated findings in these pediatric autopsies. It took until the 60s and 70s for child abuse, battered child syndrome, or shaken baby to really take hold as a possibility for these deaths. In the early 1960s, clearly I've given you a lot of background here, but there was still a lack of consensus internationally and nationally. So people in Britain were using the concept of cot death, which here in America they felt was misleading because our children slept in cribs or in different, or even in the bed. And so a few members, 10 actually to be exact, of which the forensic pathologist was a minority in that panel, came together and concluded that they would use sudden death syndrome to describe these cases. You can see that panel came back together 6 years later because there was still no consensus. And at this convention, in this conference in 1969, they proposed sudden infant death syndrome, which is still in use today. It was defined, it had a better definition in hopes that it would gain consensus a little more quickly, in that this death would be unexpected by medical history, and with a thorough postmortem examination still failed to demonstrate a cause of death. There was still some gray area in what constituted a thorough postmortem examination, which is why we're still talking about this today. Also in the publication, I would be remiss if I didn't mention about beyond infancy. So a lot of the text and a lot of this presentation today is going to focus on infancy, but it's important to understand that this occurs throughout all of the pediatric age group. And so when they looked at actual non-traumatic childhood deaths, you would see two peaks, and this is still true today, in that 1 to 4 year age group would have a high number of undetermined or infectious related deaths. And then the 14 to 21 year age group who were dying non-traumatic deaths in an unexpected way were really having these heart and brain related findings that they weren't expecting, and through a postmortem examination and autopsy and further testing were able to diagnose that. Throughout this time period, I hope you're seeing that there's sort of a mechanistic shift here. There was focus that maybe these deaths were due to infectious agents. Then it sort of became, well, no, it's a hypoxic-related environment and possibly related to prolonged apnea and sleep. What this should go on to show you is that a history and a scene investigation are of vital importance to be able to investigate these deaths. And so in 1985, one of the primary individuals who named SIDS finally denounced it as a single entity and said rather it's more of a heterogeneous group of pathogenetic phenomena rather than a single entity leading to these deaths, which is really what a syndrome is used to describe. So at this point, we started shifting to scene investigation, medical legal death investigation, and forensic pathology involvement for really figuring out why these unexpected pediatric deaths were occurring. This is about the time when the Back to Sleep campaign began and the public health initiatives for safe sleep were instituted. Also around this time in the early 90s, the triple risk model became something that experts were speaking of. Essentially, a vulnerable infant at a critical development period in their early life experiences some exogenous stressor. Let's just say it's an unsafe sleep environment, and the culmination of those three things together put them at a greater increase of death. At this point, it was still called SIDS. In 1996, the CDC released guidelines for investigation and reporting of unexplained or unexpected pediatric deaths. In the early 2000s, expert panels still holding on to the SIDS designation decided to refine it into various categories. But about 2005 to 2007, experts really were starting to get away from the SIDS designation and move more to the sudden unexplained infant death category. Dr. Krause in 2005 published a paper looking at sudden unexplained deaths in childhood, which is beyond the infancy period, and named the National Association of Medical Examiners, then went on to provide a position paper for how to investigate sudden unexplained infant deaths. But here we are in 2020 still talking about it. So I want you to... hopefully at the end of this, we'll all agree that there is a more consistent way to handle these deaths. We are still talking about it because they are still happening. So this is the most recent data from the CDC. You can see it's up to 2017. But primarily, sudden unexplained infant deaths are still occurring across the country. And you can see that we here in the South are experiencing higher rates than some of the other states. The graph or the pie chart on this slide also shows you what actually is being counted as a sudden unexpected infant death, and that is the designation of these deaths related to SIDS or sudden infant death syndrome, unknown causes, which you can see make up a fair proportion of these deaths, and accidental suffocation, strangulation in bed. I'll tell you a little bit more about those designations as we go on and get to the certification section. So what happens is we start shifting away from putting SIDS on a death certificate, and now our vital statistics and our mortality data related to this age population is really becoming very murky. There's no consistency among certifiers, and more recently you can see the green line on this slide is starting to rise a little bit quicker than the rest. And a lot of these cases are being lost in an undetermined or unknown bucket. And that cripples the ability to provide research and do really figure out what is placing these infants at risk. The more concerning line, of course, is the blue line, which has stayed stable since the initial success of the Back to Sleep campaign. what we've noticed, or what we know, is that we can't actually do randomized controlled trials. That would be wholly unethical. So these risk factors are actually just associated, and we can only document them in case control studies, which is important and a reason why we don't need to lose them in the unknown category. These risk factors that I'm going to show you on the next couple slides were actually established before the shift away from SIDS. I told you all the way back to 1892 they were publishing on what might be placing infants at risk in children. You'll see here this is a chart showing the race and ethnic groups, and you notice that a fair amount are shifted to the left in the Alaskan Native American Indian and non-Hispanic Black cultures. Other risk factors or demographic risk factors associated with infant death are low maternal, socioeconomic, educational status, as well as young maternal age and access to prenatal care. The environmental risk factors, such as prone positioning, which means placing an infant or an infant being on their stomach during sleep, bed sharing, parental smoking, and prematurity and low birth weight, have also been found to be associated with death in infancy. I'll explain a little bit more about why that is. So prone positioning has been shown to increase the risk of hypercapnia and hypoxia, which just means an increase in carbon dioxide and a decrease in oxygen, which is necessary for life, of course. Prone positioning places an infant at risk of overheating. It also changes the autonomic control of their cardiovascular system, so the message from their brain to their heart. It's also been shown to require increased arousal thresholds. So this is that concept of, hey, my brain is recognizing something's not right, I need to wake up and move, and that tends to, it requires a higher threshold when they're in a prone position. Tobacco exposure has been shown to be a fairly dose-dependent risk factor, and it's even, some publications have gone on to estimate that a third of these deaths may be prevented if all tobacco exposure was eliminated. It's very hard to tease out prenatal and postnatal smoking exposure and how that might play a role, but if all were eliminated, then some of these deaths may have been prevented. Bed sharing and the presence of soft bedding is a huge risk factor. Unsafe sleep environment tends to be one of the most common characteristics in these deaths. It's particularly dangerous when a caregiver or an adult bed sharer has consumed alcohol or are altered in some way. Babies should never be placed on a couch or a cushioned surface to sleep. And research has shown that you should use caution in allowing long-term sleep and sitting devices or car seats, especially for those that are less than 4 months of age. Some protective factors. I apologize. This slide should say protective factors, but these are good things that we want babies. We want them to share the room with their caregiver. Room sharing has been shown to be protective, but just not bed sharing. The infant should be placed in an environment that is their own, with a tight-fitting mattress and a crib. The feeding of breast milk, either through a bottle or breastfeeding has been shown to be protective, as well as pacifier use. And interestingly enough, pacifiers are protective even if they come out of the mouth during sleep. So I just wanted to talk about a few other categories that rather than just infants. So we're aware of sudden unexpected deaths that occur in athletes. This is rarely reported in the prepubertal age, but it is thought that it does occur in that younger age group as well. Typically, these are found to be due to a cardiac etiology, either a hereditary or an acquired heart illness. The children with a history of epilepsy and or febrile seizure are also at risk of unexpected death. The publication you see on your screen was just is available, open access from 2019, looking at risk factors associated with sudden death in childhood and the potential risk of having a febrile seizure. Most of these events do occur during sleep as well, and apnea, or a decreased respiration, may be, or lack of respiration rather, may be the only symptom in infancy. So these are areas that are very important for research to continue. We do sometimes see deaths in childhood and infancy clustering in siblings. This could be related to genetic associations as well as other modifiable behavioral risk factors in the caregivers. The important thing is to notice that our ability to study these deaths is limited based on the certification practices and the variety that still exists. Our ability to study a genetic predisposition to these deaths has actually expanded. We can do now sophisticated testing in conditions of the brain, the heart, inborn errors of metabolism. There's also sophisticated testing platforms for infectious agents that can be done in the postmortem period. What all of this should say is that even though the examination has become more sophisticated, the medical legal death investigation and understanding the circumstances surrounding their death is still critically important. So it is true that children are not small adults. They all have different concerns. They all have different developmental abilities, and they all reach milestones at a different stage. It is important that any child death that falls under the jurisdiction of a medical examiner or coroner be investigated thoroughly and independently of law enforcement. Both groups, all groups associated with pediatric death, have different goals in mind. The information in this investigation is drawn from parents, caregivers, other relatives who are often very distraught, either at the scene or at the hospital. And so it's a very delicate balance in getting the information you need and being sensitive to those, to all the victims. A scene investigation is critical. It's timely. It should be performed within 24 hours, and it has to go back to where the child was found, their environment. The child's environment actually plays a very large role in the investigation, whether it be an infant or another member of the pediatric population, depending on their age. Their actual environment really matters and helps us understand what might have led to their death. In cases of death that occurred during sleep, the sleep environment must be documented. You have to go back in our state primarily, and really across the country. Children that are found at home are scooped and they are transported. So a number of these deaths actually are pronounced in a hospital, but it's critically important that you go back to the scene and the environment where the infant was found. The panel recommends that a doll reenactment is performed, including where an infant or child was placed to sleep and then where they were actually found. It is important to avoid using something in the residence if possible, just because there's a lot of emotional ties tied to those items. These are some examples of dolls that you could have at your disposal. They can either be nondescript, weighted dolls, or ones without clothing. You can, of course, have them in a variety of skin tones, but you want to make sure that that you can accurately depict how they were placed and how they were found. Photographic documentation of the overall scene is also important. So you want to document the availability of food and necessary care items. What's interesting is typically there is a safe sleep environment in the residence, in the environment. It's just not being utilized at that time. But you want to document everything about the residence and where they're found. What may not be immediately obvious is you want to try to figure out the clothing. If an individual was sharing a sleep surface with the decedent, that you want to find their clothing, because there may be evidence on their clothing of overlay, and that may be what helps you determine that. It's important to document the body, including where they're found, the clothing, the blankets, any items that are around them. You want to document their lividity pattern. If you notice, the pictures on the bottom right of the screen show you some blanching or some pallor to the lividity, that red discoloration on their body. So it helps us understand what position they might have been placed in or found in or died in. Any visible injuries that may be very faint, there's a contusion on the side of this infant's head, as well as any evidence of medical intervention, which you see there in needle puncture sites. If the child wasn't transported initially, it's really important that the removal of that child is done with care and compassion. We recommend that they not be placed in the body bag in the residence, but rather transported out wrapped in a sheet or a blanket and carried to the vehicle that way. Some states and jurisdictions have laws that allow or disallow the viewing of a deceased child, but if it is allowed, it is important that it's done under supervision and that you can be as accommodating as possible without jeopardizing any investigation. Because at this point, in the view of law enforcement and perhaps others involved in the case, the parents and the caregivers are actually still suspects. So it's important to understand that the investigation needs to continue, but keeping in mind that these are grieving individuals too. There are child and infant death reporting forms available. It is recommended that you use one or at least develop one, utilize one to help develop for your office. It's important that you ask all the questions all the time as soon as possible in an effort to not simply come across as interrogating in this delicate time period. These are examples of the reporting forms that exist now. There's one that's been recently revised by the CDC, and then through this panel that I was a part of, we developed one for child deaths, which are vastly different in the investigative phase than infant deaths. Both of these are available online. They're also available in the appendices of the reference textbook. So I know the audience may not be responsible for performing autopsies, but I want everyone to understand what really should go into the postmortem examination period in these deaths. An autopsy must be performed in all sudden unexpected deaths in infants and children. It should be performed promptly and thoroughly, primarily to preserve the quality of diagnostic specimens. If you have access to a pediatric radiologist or a hospital that can perform a full skeletal survey, that is preferable. A number of medical examiner offices only have access to a plain film x-ray, but a radiologic skeletal survey should be performed. It's important to diagnose fractures, both acute and remote. Histology, which is looking at the tissues under the microscope, as well as comprehensive toxicology testing, must be performed in all of these cases. If after the examination you have not found a cause of death, which means the death is still unexplained, so it was unexpected in the beginning, it is still unexplained after an examination, then you would want to submit samples for microbiology to detect any infections. Molecular testing could be considered in conjunction with those cultures, as well as a chemical analysis of the vitreous fluid, which is the fluid that's in the eye, which is a good way to detect glucose levels and electrolytes in decedents. Specific autopsy practices are outside the scope of this presentation, but they are very clearly outlined in the reference text. It is important in all of these individuals to preserve a specimen, primarily a lavender top EDTA tube of blood at a bare minimum for later genetic testing. This has become nearly critical in cases of sudden unexplained death in children to evaluate any genetic associations, cardiomyopathies or channelopathies. There's procedural guidance that the text goes into great detail, but I wanted to point out that communication should be considered a step in your examination or in the autopsy. So preliminary results should be reported to the family or to law enforcement and to other stakeholders that are involved in the case as soon as they can. Final results and the cause of death should be reported to the family and other stakeholders in a variety of ways, verbally, either with a scheduled appointment, including multiple individuals who can help relay the same message, and in writing, which is through usually an autopsy report. The autopsy report should include a detailed opinion or summary section that explains the rationale for this cause and manner of death. When you hear from families who have experienced sudden unexplained deaths in infancy and childhood, and they receive a piece of paper that says undetermined, without any rationale and without the opportunity to ask questions, it becomes a very distressing part of their life that continues for many years. One of the aims of the panel was to think about other ways these deaths could be captured. The data could be captured other than a narrative report and other than the death certificate. The challenges with death certificates are, and especially in these cases, is that there is a wide variety of detailed investigative information that has no way of being conveyed. The investigative reports are helpful if states are participating in a registry. They may be able to capture these data elements, but it's not readily gathered across the board. And this is a crucial surveillance information for public health initiatives that's being lost, especially since the shift away from SIDS. The wording on the death certificate that could completely change at the back end of what the certifier actually wanted, and I'll explain that a little bit more in a few minutes. Death certificates really work well if you have a clear diagnosis, a clear way to certify their death, and you just want to convey some major scene investigative points like the place of death. So what a synoptic report can do is it can help give clarity and really report the details at multiple levels. Synoptics reports are in use in medicine already, especially in pathology for reporting different tumor diagnoses. And so we recommend, and we have proposed and developed a synoptic report that includes these basic elements that could be given in association with that autopsy record or to other interested stakeholders. The most important part is that the death certificate is still our primary tool for vital statistics and public health data, and so these deaths really need to be certified in a consistent way to reflect the accuracy and the intent of the certifier. Which brings us to death certification. So I'm going to give you guys a little primer in death certification, but before we go further, I'm sure you've even picked up on how I have used interchangeable words. So these cases have been caught up in this bag of words for many, many years, and our hope is that we can clarify that as we move forward. So I alluded to this earlier, but a sudden unexpected death, this says in infancy, but you could think of it as in the pediatric population, is really an umbrella term that includes those that become explained either through a natural means or through unnatural means if they're found to have accidental or non-accidental trauma, or they're left unexplained after an examination or after an investigation. Some of those are left just fully undetermined. That may be because there's an insufficient investigation that has occurred. And then those that have a thorough investigation, a thorough examination, and we've really exhausted all the options, those are the ones that we're talking about. Those are the ones that remain unexplained and have been historically referred to as SIDS. So I hope this doesn't send you running, but before we go forward, I would like for all of you to understand about simple ICD-10 coding and what happens to the death certificate after it is completed. These are 3 codes. ICD-10 codes are international classification codes for disease. They're used across the world to help standardize mortality information. R95 is the code that is defined as sudden infant death syndrome. It applies to a death that occurs in an individual who's less than 365 days old. And what's written on the top line of a death certificate, which is pictured here, includes the words sudden and death. If those 2 words are there, then R95 is how that is coded. If the individual is greater than 365 days, then there are a group of codes in the R96 family for those deaths. That would be the sudden unexplained death in childhood code. R99 is essentially the wastebasket of ill-defined, unspecified, undetermined, unknown. And this, unfortunately, is where a number of these deaths are being reported at and therefore are lost in the bucket of all the other unknowns and undetermineds. I've put 2 references down there. Those are the ones I alluded to in 2005 and 2007, which were published by a group of forensic pathologists and others, as well as the CDC to help the investigative process in these deaths. So I just want to give you an example, and for those of you who are not familiar with Part 1, which I'll talk about in a few minutes, and Part 2 of a death certificate, that's what's on the screen now. So even as a forensic pathologist, I certify nothing as SIDS. I have in the past used sudden unexplained infant death because I specifically don't want to say SIDS. That's my intent, and yet that still would be designated as an R95 or caught in the SIDS bucket, if you will. It's also important to me that I relay that this person, or this individual, this infant, was in an unsafe sleep environment, which I would have put down in Part 2, or where we tend to put contributing factors to death. This information is then lost. There is no coding mechanism for sharing a sleep surface with two adults. So even though my intent was to provide information to people who may want to research this area with mortality data, that is in fact lost. The next few slides are going to be a little busy, but I think they will, hopefully it will become clear as we go through. So what you're seeing here is in the first column is Part 1, that top line that I referred to earlier, that immediate cause of death line. And you see, regardless of the words, if sudden infant death syndrome or sudden unexplained infant death is used there, you're going to generate an R95 code. Even if you put bed sharing, prone sleep, other risk factors in the Part 2, it's still shifted to an R95. Even if you add something like possible or probable asphyxia due to bed sharing, again, this is not a more specific code than R95, therefore it doesn't trump R95. And all of these pieces of information are then lost in the greater scheme of vital health statistics. If you were to put the word overlay on the death certificate, again, we recommend this is only done when a doll reenactment or sufficient evidence is there to say overlay occurred. But if you put overlay in Part 1, in one of those subsequent lines in Part 1, it will actually generate a W75 code, which is defined as accidental suffocation and strangulation in bed. I'll show you the chart again, but you may remember that was on that chart that I showed from the CDC. If overlay is listed in Part 2 in the contributing factors, it will not trump the sudden infant death or unexplained infant death designation in Part 1. And these deaths, again, are lost in R95 as just SIDS-related deaths. Just a word about undetermined. Undetermined is going to generate that R99 code. Regardless if you put risk factors, it's still going to be there. What might happen is if an individual has the intent to share a finding. Acute tracheitis is sometimes found in these children. We're unsure of its significance, but it is a finding. And if my intent is to provide researchers and individuals in public health findings, then I may want to put that on the death certificate. It's the only tool I have at this point. But that actually has a specific code, and it would trump the R99 or the undetermined, and therefore this would get a J041 code and be completely lost because that's not even counted in the cases of sudden unexplained or unexpected infant deaths by the CDC. So this is that chart again with just some clarity about what ICD-10 codes are associated with these curves that you're seeing here. And so anytime, since there is no consistent approach, we have to look at all of these baskets and the individuals within these baskets to understand what's really going on. And we really have not been able to identify risk factors that are within those different groups. So just to drive the point home a little further, this is one story, one infant in an unsafe sleep environment, certified 3 different ways and generating 3 different codes. And so you can see that if you had a group of death certifiers in a room, that you may be generating a whole host of varieties of information from the death certificate in these cases. It's still important, though. I've shown you that it's actually not gone away, and it's so much so that it's still listed in the top 10 leading causes of death in infancy. And then if you were to use all of the codes that might be related to sudden unexplained death in childhood, it would also rank fairly high in a number of age ranges in the top 10 leading causes of death, primarily in that 1 to 4 age group as well as more. So it's important that we come up with a way to help everyone understand what we're talking about. We, as in those that are tasked with certifying these deaths and investigating these deaths. So on one side, you have the explained natural group that are still dying unexpectedly and suddenly, but we find out a reason why. You have the explained unnatural group, still dying suddenly and unexpectedly, but we have a reason why. Where we're left with is the group in the middle that have been called a multitude of different things. And what we now know is that there are multifactorial reasons for these individuals to die. It could include some intrinsic or natural factors. Maybe they have an enlarged heart that wasn't known about, or maybe we find some congenital malformation that was unknown. That would be an intrinsic factor, and it's important that we are able to transmit that information. It may be that they have an extrinsic factor, meaning something about their environment or something outside of their body was at play here. That would be an unsafe sleep environment. Also still important for us to talk about. They may also have both of these occur in the same case, and therefore we have intrinsic and extrinsic factors available. And once the panel decided that this is really the message we want to transmit, then we said, then that's how we certify the death. And so moving forward, this is already in place in my office in Jefferson County. We certify deaths with this terminology. So it's an unexpected sudden death when it occurs. If we do not explain it during the investigative or postmortem examination, it is now unexplained. It is still a sudden death, and so those go on the death certificate. I don't need to say infancy, and I don't need to say childhood. The age is already on the death certificate. I would just be repeating myself. If they're less than 365 days, the coding system knows what to do. If they're greater than 365 days, the coding system knows what to do. So then I would go on to make sure that I explicitly say there are no identified intrinsic or extrinsic factors, meaning I've exhausted all of my investigative and medical knowledge, and I have nothing to help explain why this individual's dead. It may be that they solely have intrinsic factors, an enlarged heart or a congenital anomaly or a genetic polymorphism for prolonged QT syndrome, things that might have put this person at risk, but not so much that I can actually say that specifically caused their death. It may be that they have an extrinsic factor. They're in an unsafe sleep environment. They're bed sharing. There's something else going on with the environment, and I think that might have played a role, but I'm not so sure that I can explicitly say that too. Or they might have both factors there. We still have undetermined in case there's just nothing else you can do and you can't get into one of these other baskets, then you would put undetermined, not further specified. And then if the data is just insufficient, your office is not in control of the investigation, you haven't got the information you need, you don't have any medical records, then this is still an insufficient data. The asterisks are down there in that this panel and the group of experts I showed you earlier, we're at the meetings with the ICD-10. ICD-11 will be coming out soon, and we propose that the title of the code not simply be SIDS anymore. SIDS is used across the world still, so it can't go away, but those of us in North America for sure are really hoping for a change in the title of the code to not just be SIDS. I would be remiss if I didn't mention asphyxia. So asphyxia meaning the airway is blocked or the child is unable to breathe. This could occur in an overlay. This could occur if an infant becomes prone or face down and their airway is blocked in bedding. In order to put probable, possible, or just flat-out asphyxia on the death certificate, it is recommended that a complete and full autopsy be performed, including additional testing and review of medical history, as well as a doll reenactment saying that obstruction of the nose or mouth or compression of the neck or chest was reliably witnessed. What we found is that a number of these deaths were being shuttled into the asphyxia category, when in fact that may not have been completely true. Asphyxiation must also be probable given the infant's age, so that they are unable to turn themselves over, or they're so small that a person could roll over on them and not know. And then, of course, that there's no other reasonable competing cause of death. So I think I have some case studies to just go through. I've pretty much given you these examples already, but I just want to drive the point home a little bit more. If you have in this case, you have a previously healthy, term-born, 3-month-old boy who was placed on his side and later found prone, face down, on an adult bed. The photographs and the scene investigation documents numerous pillows and blankets nearby, but a doll reenactment does not conclusively demonstrate obstruction of the airway. Medical record reviews show no chronic or acute health problems, but the heart was greatly enlarged at autopsy. An enlarged heart has the possibility of having a fatal arrhythmia at any point in time, at any age, and so this is a pertinent intrinsic finding. All the other testing was non-contributory, and so this death would be certified, all of these words listed on the death certificate: unexplained, sudden death, with intrinsic and extrinsic factors identified. The manner of death is still undetermined because you have a competing accidental manner with the environment and a natural manner with the enlarged heart. In this case, 4-month-old infants placed supine, meaning on the back, the way that we expect them to be placed, on soft bedding between 2 adults in a queen bed. The infant was found supine still hours later, but unresponsive. The doll reenactment does not reveal overlay, and review of medical records, autopsy findings, and testing were all non-contributory. Cardiac channelopathy genetic testing was performed, and a mutation for prolonged QT syndrome was detected. This is something that can place individuals of all ages at increased risk of sudden death. Therefore, that is a pertinent intrinsic finding. The soft bedding and bed sharing is an extrinsic finding. This again is certified as unexplained sudden death with intrinsic and extrinsic factors identified. Competing manners of death still make this an undetermined case. I hope that section, although it is a little challenging to understand at the front end, I hope it's a little more clear. But again, the reference text goes into these separate categories in much greater detail than I was able to do today. We're going to wrap up. I just want to tell you a little bit about the family needs section of the text and what the panel recommends in relation in relation to the interagency communication and professional relationships. So there's guidance in the text for how different agencies intersect with these pediatric deaths and different protocols that can be in place. The most important thing is that you don't wait for one of these deaths to occur in your jurisdiction before you mobilize these units. And so it's important that you have access to your investigators, you have access to the social work and DHR, and you have access to each member of the team, including the first responders, so that everyone knows what to expect from everyone else when one of these unexpected pediatric deaths occurs in your jurisdiction. It's important that everyone understand each other's roles and what message they're responsible for transmitting to the family. It also goes into the role of child death review committees, which some members may be responsible for the preliminary stuff, but a lot of times, as most of you are probably aware, child death review committees are going to come in place many months later. This is just a small list of the individuals that may be responsible for a portion of a sudden unexpected pediatric death, and so it's just important that each agency is able to work together with a single goal in mind. Although each are going to have their own avenues and their own roles to play, it's important that we all are working together. Primarily because there are still, other than just the child or the infant who is, in my case, that I'm examining as my patient, really my patient population is expanded to include those caregivers and the family members and the siblings. And, the pediatrician who is going to go on and care for this family and the siblings. Everyone needs to be aware that the grief process is not as straightforward as we really want it to be. And so we want to limit confusion. We want to help the families understand who's involved, why they're involved, and what our goals are and what our findings are at the end of that examination and investigation. It is important that that investigation is complete and thorough in order to help foster as much positive outcome as can be expected in these challenging cases. Those of us who do not have the goal of, as law enforcement would need to make sure there is no criminal intent, we need to make sure that we're presenting an unbiased and non-accusatory message to the parents, with, of course, the utmost respect for them in their challenging time. If they can see and hold their child before they are transported, the most powerful part of this panel is that a few of the members were parents that had lost their child and suddenly and unexpectedly, and to hear their stories and what that piece really meant to them was very valuable. And so being able to hold them or see them or tell them bye was really important to the family members. And if it can be done, it should be done. Of course, timely communication really helps their long-term bereavement outcomes. Individuals who receive a single letter in the mail 6 months later without any provocation or notification experience that grief over and over. And so it's important that there's a single point of contact, but that every member of the team understands what their communication role is and what their message should be. It's important if you're not one of the individuals who are providing services, grief support or medical follow-up, those sorts of things, that you do have access to those members. So if a family member were to call your office, that you have a place to send them or a reference to give them for these support services after experiencing this loss. We recommend that those of you in the medical examiner and coroner community consider having a post-autopsy conference with family members and other stakeholders, including the pediatricians and the clinicians that may be following up with this family. Because above all, each one of us and the investigation really becomes a part of the long-lasting history of this family. With that, I would like to thank you for the opportunity to come and present this information. As I mentioned, it was a long project of a lot of people's time and effort, and the SUDC Foundation really supported this effort fully. I appreciate the Alabama Department of Public Health inviting me here, and I welcome any questions.
I do not see that we have any questions via email. Do we have any questions or statements from the audience? All right. Well, thank you, Dr. McCleskey.
Thank you.
This concludes our program for today. I want to thank Dr. McCleskey for being here and thank you for watching. Please remember that you can refer to our materials and this program again on demand. Have a good day.